Thank you for attending our webinar today. The topic is peritoneal dialysis, and my name is Anjay Rastogi. I'm a kidney specialist and I work at UCLA, and we'll be talking more today about home dialysis. So before I get into the slide deck, I just want to mention March was National Kidney Month, and green ribbon actually signifies kidney disease. So we started the green ribbon campaign a couple of years ago at UCLA, and it's doing fairly well. Before we get into dialysis as a modality for advanced kidney disease treatment, let's just recap a few key things about kidneys themselves. So we have two kidneys, as you can see over here, and they are in the back, right over here in the flank area. They purify your blood, they filter your blood, and this filtered blood then comes through your ureters and comes into your bladder where it's stored, and eventually it comes out through the urethra. So that's the normal path urine takes. What do your kidneys do? Kidneys are one of the most complex organs in your body, and they do multiple functions. They purify your blood. They're heavily involved with acid-base electrolytes and fluid management in your entire body. They are also heavily involved with drug clearance. So the medications and the drugs that you take are cleared by the kidneys. They also have a lot of hormonal functions, including anemia management. So the hormone epogen is synthesized by your kidneys, and vitamin D activation also happens in your kidneys. And kidneys are also very central to blood pressure management. So kidney disease causes high blood pressure, and high blood pressure also tends to cause kidney damage. So it becomes a very vicious cycle. So how do you know your kidneys are not working properly? And when you have kidney disease, you can have multiple manifestations. One could be as simple as swelling. Your hands are swollen, your face is swollen, your legs are swollen. You can have back pain. As I mentioned, kidneys tend to reside in the back area. You can also have blood in the urine. You can have protein in the urine that can appear as frothiness. Your urine output could be dropping. Or there could be some other manifestations like what we call non-specific. You can have fatigue and nausea. But the key thing is that in majority of cases, the kidney disease tends to be asymptomatic, even in advanced stages. So why am I mentioning this? It's very important that you get regular blood tests. And that's the only way in majority of cases that you can see, number one, if your kidney disease is advancing, and number two, how much advanced it is. So with that bit of background, how do you assess your kidney function? So you want to get your kidneys tested. And there are a few tests that what we call basic tests that we do to assess kidney function. One is a simple blood test, and we check something called creatinine that's highlighted over here. But creatinine by itself has a lot of limitations, so a better test that we use for kidney function is called GFR. So one test that I would like you to remember from today's presentation is GFR. That stands for glomerular filtration rate. This is the single most important test that we use to see how your kidneys are doing overall. We can also test your urine, and we check for protein in your urine. So if you're spilling protein, that means your kidneys are damaged, and we monitor that very closely. And then also if all these things are still needed, we can do some imaging studies. You can get an ultrasound, CT scan, MRI, and finally at last resort, if we still need to make sure that you have, or what kind of kidney disease you have, we do something what we call a kidney biopsy. We put in a needle into your kidneys and take a small portion of the tissue and look at under the microscope. So these are the main tests that we do, but from your perspective, I think what I really would like you to focus on is GFR. This is a test that you should all know values. For example, when we are diabetics, we look at hemoglobin A1C. When we have heart problems, we look at cholesterol and LDL. When we have blood pressure, we also look at the blood pressure numbers, that what your goal should be. When you have kidney disease, you should have a number called GFR. That's a test that you should always remember and have that. There are two kinds of big categories of kidney injury. One is acute, the other is chronic. Acute means that it happens suddenly, acutely, and the hope is that once we remove the acute insult, the kidney function will recover. The focus of today's topic is chronic. This is a chronic disease, chronic kidney disease, and it tends to progress over time. So that leads to a more chronic management of this, and a lot of these patients tend to progress to ESRD, what we call end-stage renal disease, and I'll be going over that in a lot more detail. This is how we define chronic kidney disease. So if you have any evidence of kidney damage for 3 months or more, and these are all the evidence of kidney damage, then the patient will be qualified and classified as having chronic kidney disease. So the cutoff that we use is 3 months. Now, I mentioned GFR. This is an important slide. So once you know your GFR, your normal GFR is above 90. And as your GFR drops, your kidney disease advances. So the first stage of kidney disease is stage 1, and as GFR dropping, stage 2, stage 3, stage 4, stage 5. And this is what we call end-stage renal disease. This is stage 5 CKD, is a stage that your body will need some help. So the kidneys cannot save your body by themselves. So, and what help? So either that you will need dialysis or you will need a kidney transplant. So this is what we call ESRD stage 5. But let's go over these stages in a bit more detail, because it's important in what stage you're on. So if you come to me in stage 1 and 2, my job is to revert your kidney disease or slow it down as much as we can. And this is through different treatment, management, but also there are a lot of clinical trials that are going on. So if you qualify for a clinical trial, I probably would enroll you in these stages. Now, stage 3 is a stage that's GFR is below 60. Then you should be looking at some of the complications that can happen with CKD. For example, anemia. You can have blood pressure. You can have electrolyte problems, and that starts happening once your GFR falls below 60. Now, stage 4 is a GFR is below 30, and this is a time when you should start thinking about replacement therapy, for example, dialysis or transplant. And your nephrologist will be working with you very closely to make sure that this transition that happens into stage 5 and eventually into dialysis and transplant is as smooth as possible. And how does it make it smooth? It's by preparation and education. So a big focus over here is on education, is giving as much education as we can, not just to the patient, but to their families as well. Now, one of the numbers that is important to remember over here is 20. So when your GFR falls below 20, then you can be evaluated by the transplant program. So in our practice, anytime a patient hits GFR of 20 or below, we automatically refer them to the kidney transplant program. They evaluate the patient and see if they actually are qualified to get a kidney transplant, and if they are, they go on the waiting list if they don't have a living donor. But if they have a living donor, then there is a pretty good chance, especially if you get an early referral, that you can bypass dialysis completely. And this is what we call preemptive transplant. So the important point over here is know your GFR, get referred to a transplant program early, and if you have a living donor, make sure that they actually also get referred to the kidney transplant program so they can evaluate the donor. And if you have any questions, I'll give you my contact information and also the UCL transplant program information. Feel free to call us or email us anytime. But a good number of patients don't have living donors. And the wait time is so long for deceased donors that there's a pretty good chance that they will end up on dialysis before they get on transplant. And that's where the modality education really comes in. That when you're on dialysis, there are choices you can make. And to make the right choices, you have to be educated. So the purpose of this webinar today is to educate you about the existence of home dialysis. And in the future webinars, we'll be doing a much more deeper dive into home dialysis and specifically more peritoneal dialysis. Now, this is just a summary of optimal care for CKD patients. So as mentioned over here, it's early detection is critical. And once we have done that, we want to delay progression as much as we can, prevent complications that happen with kidney disease, treat the comorbid conditions, and if you have advanced to the advanced CKD stage, then we want to prepare you for replacement therapy, whether it be transplant or dialysis. So as again, the key focus is in preparation. So we want to prepare you to make this transition. This is a very stressful time in a kidney patient's life when they're transitioning to transplant dialysis, and this could be made much smoother by education and also involvement of your family and loved ones. Now, what are the modalities available for what we call renal replacement therapy. So renal is a term that we use for kidneys. So we can call it kidney replacement therapy or renal replacement therapy. And these are the three big categories. The number one is dialysis, number two is transplant, and the third one is palliative care. So let's talk about palliative care. So if a patient is not either eligible or doesn't want dialysis or transplant, then we put them on what we call palliative care, and this is basically we manage them conservatively. So this and a lot of patients actually this might be the best modality, but for a good number of patients, transplant is the best. And among transplant, we really want to focus on living donors. But this is going to be a separate topic, so we won't discuss too much of this. But our topic today is dialysis. So if you are either on dialysis or are getting close to dialysis, then this is an important place to think. That number one is, do you feel prepared? Do you think you have been given enough information about dialysis? And most importantly, have you been given the option of being dialyzed at home? And I'll be going over some of the advantages of home dialysis. But home dialysis is in our practice at UCLA, home dialysis is our go-to modality. So, and even among home dialysis, we prefer peritoneal dialysis. So if you're getting close to dialysis or on dialysis, the question you need to ask is, will you qualify for home dialysis, specifically peritoneal dialysis? Hemodialysis is a modality in which we actually access your blood, take out the blood, pass it through a machine, purify it, and put it back in. So the hemo meaning blood. So that's hemodialysis. Peritoneal dialysis is done through your own endogenous cavity called the peritoneal cavity. And this is a cavity in your abdomen that we put fluid in and use that for dialyzing. So some terminologies that you should be aware of. One is in-center, ICHD. So in-center hemodialysis is when you go to a dialysis unit, get dialyzed there 3 or 4 times a week, and then go back home. This is the way patients were normally dialyzed, and we still have the majority of patients are in-center. But the move and push is now to get patients on what we call home dialysis. So they can get dialyzed at home. They do have to follow up with their nephrology team on a regular basis, but their dialysis sessions happen at home after they've been fully trained. So the key thing is that you do have to go through a training. Now, one point that I do want to mention over here is in-center hemodialysis. There's not that much work the patient has to do. They need to get the right access in for dialysis. They go to the dialysis unit, get dialyzed, but there are a lot of shortcomings and downfalls of in-center hemodialysis. Home dialysis has a lot more advantages. But in home dialysis, you have to do a bit of preparation, and you also need to get trained properly. And at the end, the nephrology team has to feel comfortable that you can dialyze at home, and you need to feel comfortable that you can dialyze at home. And if either one of us don't feel comfortable, then you cannot get. So we need to sign off that you can dialyze, and it's all about safety. So the patients need to be safe at home. So training is very, very critical in home dialysis. This is something that you don't have to do for in-center. You just go in and get dialyzed. There are 2 kinds of home dialysis. One is called the peritoneal dialysis, and there's home hemodialysis. So home hemo is not the focus of our topic today, but in home hemo, you once again, just like in-center hemo, you go in, you take out the blood, goes through a machine, purifies it, puts it back in. Peritoneal dialysis is when you use your own body cavity, the peritoneal cavity, to clear your blood. And there's also something called nocturnal dialysis. Here you go, nocturnal meaning night, you go at night to the dialysis unit and you go for extended periods of dialysis 3 times a week. There is some benefit of extended dialysis in fluid management, electrolyte management. Sometimes patients feel well as well, and they get done at night, so it doesn't affect their day work. Now, what is peritoneal dialysis? So the peritoneal cavity is a cavity inside your abdomen, and this, as you can see, the white area is your peritoneal cavity. We put a catheter in that goes just under your skin into the peritoneal cavity. We put fluid in, the dialysate, into the cavity. We let it sit, we will call the dwell time, into the peritoneal cavity. The exchange happens. The bad stuff from your blood comes into the dialysate, into the peritoneal cavity, and if there's any good stuff that we want to get into your blood, goes from your dialysate into your blood compartment. So these are the exchange happens, and the waste that we call dialysate comes out, and then is collected into the waste bag. So this is how dialysis happens. And what we normally do is once you're trained, we're giving you a machine, and a lot of patients prefer something called cycler. You go in at night, you connect yourself to the cycler dialyzes you at night, and the drain comes out into the dialysis bag. Now, there's also something called manual, and we'll be discussing this in a lot more detail in our future webinars, in which you don't use a cycler, but you actually manually hang the bag, and you keep on changing the bags as you dialyze. So it's a personal preference. Some patients like the manuals, some like the cycler. And this, like I said, we'll be discussing in a lot more detail in our future webinars. This is how the PD catheter looks. So this is a catheter that goes just under your skin into your abdominal cavity, into the peritoneal cavity. And when we hook up the machine over here, and this will exchange the fluid back and forth between the peritoneal cavity, which will eventually exchange these things with your blood. This is another picture of how the peritoneal dialysis happens. This is the dialysate fluid. This goes into your abdominal cavity through this catheter. This sits over there for some time, and after the exchange has happened, we drain this waste into this waste bag. So this is how the peritoneal dialysis takes place. This is the machine. So I want to show you a picture of the machine, and this is a drawer that's sitting. So as you can see, this is not a very big machine, and you can travel with this. So a lot of our patients love traveling. They can put this in their car, or they can take this with them on the plane. And once again, we'll be discussing this a bit more in our future webinars, how you travel with the dialysis machine. But travel is one of the big advantages of being on PD. So it gives you a much more liberty to travel. So why do PD? So there are a lot of reasons. One is independence and flexibility. So once you're properly trained, you can do dialysis at home. So you want to do dialysis at 8 p.m., you can do it at 8 p.m. You want to do it at 9 p.m., you can do it at 9 p.m. It's not like you have a shift that you have to go for in-center hemodialysis. It gives you a lot of flexibility. It gives you a lot of independence. You have something to do that night, you can do a bit later that night. Also helps people when they have daytime jobs. A lot of my patients have full-time jobs, even if they're on dialysis. Sometimes that's not possible if you have to go 3 times a week to an in-center hemodialysis unit. People go to school. A lot of my patients are students. They have full-time school and enrolled in classes and graduating. There's actually one of my patients who became a dialysis nurse while being on PD. Some need to take care of their family. So all of these things become possible because you're dialyzing at home, and also dialyzing at night, especially if you're on a cycler. So like I said, you hook yourself with the dialysis machine, let it do its job, and then in the morning you disconnect. Preservation of the kidney function. Now this is very important. Once again, I'll be going over this in the future webinars, but when you start dialysis, you're still making urine, and we should make every attempt that we preserve that kidney function for as long as we can, because that's contributes significantly to the clearance that your overall dialysis and kidneys are providing. So one of the key take-home message from today is, if you're making good amount of urine, make sure that you do everything that you can. And we'll be going in the future talks that how you can actually preserve your kidney function. Preservation of veins. So as you can see, the PD the peritoneal dialysis does not involve your veins. So it goes into your abdominal cavity, the peritoneal cavity, through a catheter, and that's all that it is. And we can always pull out this catheter. I'll show you some pictures next time of these PD catheters. But important thing is that we don't touch your veins. And one of the things I tell my kidney patients is veins are their lifelines, and vein preservation is very, very critical. Because if you run out of veins, then it's a big problem. And the only solution left after that is a transplant. So try to preserve your veins as much as you can, and that's where PD is definitely a much better modality. Early outcome benefits. There is some data to show there might be some mortality benefits, especially in the first 3 years on PD as compared to in-center hemodialysis. higher transplant rates. There is published data on this that patients who are on peritoneal dialysis, PD, as compared to in-center hemodialysis have a much higher transplant rate. And I can tell you from my own unit, we have a very high transplant rate. And the way I look at PD is it's almost like a bridge. So our goal should be to get you a preemptive transplant. That means that you don't even get on dialysis. You have a kidney donor, a living kidney donor, you get a transplant and bypass dialysis completely. But if you do end up on dialysis, then PD is probably the preferred modality, and it should act as a bridge. It should give you time to find a living donor. So transplant rates, if you're interested in transplant, peritoneal dialysis is definitely a better modality. Hemodynamically unstable patients, if you have wide fluctuations in your blood pressure drops or fluctuates, then PD is a much better, because if you think about that, when you go for in-center hemodialysis, you are dialyzed 3 or 4 hours per session, and it's 3 times. Your kidneys work 24/7, so that really does not replicate. Now PD is much more extended and it's much more gentler, so you don't have the same fluctuations that you see with in-center hemodialysis. Anticoagulation, if you're on a blood thinner, in PD we don't use any blood thinner. So in a lot of our patients on hemodialysis are on blood thinner. So if you can't have a blood thinner, then PD is a more liberal diet. Now kidney patients a lot of them tend to be diabetic, also have heart problems, so they are on a very restricted diet. But if you are on PD, your diet could become a bit more liberal, especially when it comes to potassium. So kidney patients, even on dialysis, tend to run high potassium, so we put them on a potassium restricted diet. But in peritoneal dialysis, their potassium actually tends to run on the lower side, so we have to give potassium back. So one of my patients loved mangoes and fruits, and he was very happy that he was on PD because he could eat his fruits. So you can have a much more liberal diet. Obviously this is within limits. I mean, this is not that you can eat anything and everything you want, but it's much more liberal than when you're on an in-center hemodialysis. Travel I mentioned. So this is also, if you like to travel, then PD is probably a better modality. Now PD comes in with its own complications you have to keep in mind. They could be metabolic. The solution that we use is high in glucose. There could also be some weight gain that happens. There could be hernia problems because you're putting fluid into your abdomen. Diabetes is also something we have to keep in mind. Once again, the fluid that we use for peritoneal dialysis is high in glucose, and they can also, this is something that we call encapsulating sclerosing peritonitis. This tends to happen. It's rare and happens to patients who have been, or can happen to patients who have been on PD for quite some time, especially if they have some other risk factors. But these are something. The other thing that I have not mentioned is infections. So infections can happen as well, but if you are trained properly, the chance of having infection is very, very low, if not zero. So once again, the focus is on training. We'll be going over these in a lot more detail, but there are very few contraindications, if any, for peritoneal dialysis. So if you are interested in peritoneal dialysis, talk to a nephrologist who actually is an expert in peritoneal dialysis, because a lot of times we get these patients said that they don't think they will qualify for being on peritoneal dialysis, but that's not the case. We actually put them on peritoneal dialysis, and very successfully. So talk to an expert nephrologist who on peritoneal dialysis before giving up on the modality. So speak to your nephrologist if you're a candidate on peritoneal dialysis, and in summary, learn more about kidneys. Be your own best advocate. Ask questions. There is no better advocate than yourself. Let us know what you'd like to hear more. Like I said, this is the first of a series of webinars that we'll be doing on peritoneal dialysis, and we'll be doing in a lot more detail some of the stuff, and we'll also bring in some other experts in this field, and also some patients that can discuss their own experience on peritoneal dialysis. And feedback is always much appreciated. So if there's anything that you think we could do better, please let us know. Now, I do want to end this with the Kidney Fair. The Kidney Fair is our annual event that we do every year. This is at Santa Monica Beach. It's May 5th, Cinco de Mayo Day, 11 o'clock to 3 o'clock. There's wealth of information that will be shared over here on dialysis, on transplant, on clinical research, on nutrition. There's a lot of fun events too. There is a section called the Kidney Zone for kids. There's also a spirit walk. There'll be dance, there'll be music, yoga, So a lot of fun stuff. So please do attend, and you can get all our information by let me go over here, is either you can call us at this phone number, you can email us, but also visit our website, the Core Kidney website. So with that, I want to thank you for attending our webinar on peritoneal dialysis. Like I said, we'll be doing a few more in the upcoming months, but if you have any questions, please feel free to reach out to us. Thank you very much once again from UCLA Health.